It's really great to see all of you here. So I was asked to do a year in review. And I'm probably not going to make through my talk if I follow all the warnings and everything. And the reason for that is not that I just simply like to talk, which is true, I like to talk. But I was really trying to be very inclusive and to show what all of you have done during the past 4 years by showing your publications. So that's why my talk is a little bit longer than it's what it's supposed to be. And hopefully, you know, I will make it through, but I can't be sure for that. So here where this ADA2 story started with us. Basically, it started in the year 2012 with these 3 sporadic and unrelated patients that were referred to our clinic because they presented with fevers and also some neurological features. And it took a couple of years, at least for our group, to find the disease-causing gene in these patients, to identify additional patients, and also to characterize this disease to some extent. So this work was published in year 2014. At the same time, another group from Israel published a cohort of patients that presented with childhood-onset PAN, who also shared B allelic mutations in the same gene, namely CECR1, like our patients. And as Chip already mentioned, I would like to remind everyone that the official name of this gene nowadays is ADA2. So what is happening, or where we are now in the year 2018 with ADA2? So when we found ADA2, most of us assumed that this is going to be a rare disease. But actually, I don't think it is a rare disease, and I will show you some data for that. So Chip mentioned a higher number of patients, but this is what I can say I found in the PubMed, and that also includes some unreported patients from NIH. So at NIH, we confirmed ADA2 diagnosis in 69 patients. Some of them, about 15 of them, have been already published. So there are about 50 patients that will be soon published. So we tried also to estimate what is the prevalence of ADA2, and this was done by Dr. Ching Zhu, also known as Pearl. And basically, Pearl predicted that the prevalence of ADA2 might be 4 in 100,000 people, and this was based on the allele frequencies of pathogenic variants in this gene and also variants that are predicted to be pathogenic to the protein function. However, by looking into PubMed, I noticed that we are still missing a lot of reports from some major population or large population, such as Japanese population, China, India, Africa, and Australia, and I'm sure that there are many patients in all these countries that are still undiagnosed. So the purpose of my talk today is not to review literature since the initial publication of this disease, but actually to review the literature that was published during the past couple of years. So what I'm trying to do today is basically to review and tell you about the expanding clinical spectrum of ADA2, to update you on diagnostic testing, to talk briefly about pathophysiology of the disease, and just mention briefly about the therapies. Many of the papers that I will mention in my talk will be discussed later on in details through multiple talks. So we all know that ADA2, at least before the treatment was discovered for this patient, was a fatal disease. And this was shown in these 2 publications. So in this publication, basically, they reported 3 children who died from complications of the disease. None of them was treated. The first paper that described the child who died from ADA2 was actually published in the year 2014, and this young girl suffered both from recurrent ischemic and also hemorrhagic strokes, as you can see here in this MRI, and angiography revealed major narrowing of her internal carotid arteries, as you can see here in this panel. So what we learned mostly during the past couple of years about the expanding spectrum of clinical manifestations associated with ADA2 is that many of these patients present with hematological features. And this is something that we kind of noted in our original publication, where we mentioned that a couple of our patients also presented with some immunodeficiency, that we observed hypogammaglobulinemia in these patients, but it was really not clear whether this is in the spectrum of the disease or it was just due to the treatment of these patients with heavy immunosuppressive therapies. So this is now, you know, a finding that is basically hematological and immunological manifestations are reported in up to 50% of patients with ADA2. And I'm sorry, I just have to move because I don't see really what are the papers that I'm showing, and I don't know how to do that in the best possible way, but I really don't see any of these papers. I have to turn around. So here is the first paper actually that presented hematological features in patients with ADA2, and that was the publication from Israel, which described patients who did not have any vasculitis or fever but presented with severe anemia and including pure cell red aplasia. So subsequently, a few other papers have been published. Here is another patient who presented with pure red cell aplasia. Then there is a paper from Germany that basically described 9 patients that were identified in the cohort of patients presenting with combined variable immunodeficiency, and all 9 patients had the B-allelic mutations in the ADA2 gene. So here we are introducing this idea that immunodeficiency is definitely in the spectrum of ADA2. And also here is another paper that was recently published and described a patient who presented with severe neutropenia. So here are the immunological and hematological manifestations in the other patients that have been reported in the past couple of years, and they include severe anemia. Some patients were diagnosed with atypical Diamond-Blackfan anemia, bone marrow aplasia, lymphopenia, neutropenia has been reported in up to 10% of the patients, immunodeficiency, immune thrombocytopenia, anemia, SLE, and high levels of autoantibodies, and I will show you a picture of some of the patients, and their clinical manifestation was really consistent with lupus, for example, and severe autoimmune disease. So what we also learned during the past couple of years is that there are patients that present with adult onset bone marrow failure, and these patients actually did not have any obvious evidence for inflammation. So lymphoproliferative features have been also described in few of these patients. So one patient was diagnosed with Castleman disease, and then there are reports of patient that was diagnosed with ALPS. And then here is the study from Finland, which basically described few patients that presented with clonal lymphoproliferation in their bone marrow. And this paper will be discussed in details later on today. And what is the reason why these patients present with lymphoproliferative features? It's not clear, but this is not something that is unique just for ADA2. Actually, it has been described in many other primary immunodeficiency and possibly could be explained or due to reactive lymphoid hyperplasia. So I would also like to say here is that this combination of features that we see in ADA2, namely autoinflammation, autoimmunity, immunodeficiency, is not really specific just for ADA2. So we hear more and more about that in patients with primary immunodeficiency, and basically this is just a spectrum of manifestations, and it simply could be the reason that in the past, all of us who worked with patients with autoinflammation didn't really think about looking for evidence for immunodeficiency in these patients or evidence for autoimmunity in these patients, and vice versa. People who worked with patients that had severe immunodeficiency didn't think about autoinflammation. But this is what you hear now at the meeting, basically, that many of these patients present with the spectrum of these features, and the easiest way to define this phenotype is really to say that they have immune dysregulation, without going into the details whether this is autoinflammation, autoimmunity, immunodeficiency, because you find a little bit of that in all of them. So ADA2 can be also misdiagnosed with other immune diseases, and here are a couple of reports. One of these patients was diagnosed with GATA2, and here is a paper that I found in PubMed, but I was not able to pull the abstract from this paper. And then also here is the paper that described 2 siblings. One of them was diagnosed early in his life, in childhood, with idiopathic juvenile arthritis. The other sibling in this family was diagnosed with Hodgkin lymphoma. We didn't really have any access to the records of his Hodgkin lymphoma. We do know that he was treated for Hodgkin lymphoma, but now when you think about all these new reports that are saying that basically lymphoproliferation and this hyperplasia of T cell is in the spectrum of the ADA2, it's possible that maybe he was also misdiagnosed, at the time, which was probably 30 years ago or something like that. And here is another paper that I found in PubMed. So here you can see, and I will show pictures later on, that patients may present with viral skin infections. So a couple of patients basically presented with extensive warts and also molluscum. So here are the pictures that show that skin manifestations do not include any longer just livedoid skin rash and peripheral amputations. Patients may present with severe skin ulcerations, as shown here. There is also evidence that some of the patients may present with subcutaneous nodules. Histology showed evidence for paniculitis. And here are these 2 patients from Belgium who presented with mollusca and also verrucas. Here is the family from Germany, 2 siblings who presented with livedoid skin rash and also with some strokes, as shown here on this MRI. However, they presented with a very strong autoimmune phenotype. So in addition to this livedoid skin rash, they have erythematous skin rash and also this discoid skin rash, which is very typical. I'm not going to make it for lupus, right? So, and they had strong interferon signature. When it comes to cohort study, there have been a couple of cohort studies of Italian patients and also French patients. And here is the figure from the review paper that Isabella Mates and I wrote, and also showed, the prevalence of different features, clinical features in the cohort of 160 patients that we are able to find in the literature. When it comes to genetics of ADA2, we know that there are more than 70 pathogenic variants associated or published, as associated with ADA2. Most of them are missense. However, we hear more and more about genomic deletions, duplications, non-coding mutations. We don't really have any good genotype-phenotype correlation studies. We cannot predict based on the genotype whether the patient is going to have severe phenotype or less severe phenotype. And clinical variability is seen in families and also in patients that present with the same genotype. I will just skip this figure. Here is the family that we presented a couple of years ago at the first meeting. So at that time, we were able to find only one missense mutation in this family. In the meantime, we developed this MLPA assay or kit in collaboration with a company from Netherlands and basically showed that these three siblings have exon 7 deletion as the second pathogenic mutation. ADA2 activity assay is a diagnostic test. However, it is clinical diagnostic test as that type of test is performed only at Duke University. However, our lab and many other labs throughout the world do ELISA assay as a research-based test, which is still useful to confirm new pathogenic mutations. We also use this test, for example, in patients that are suspected to have ADA2. They are mutation negative, and then we would just like to make sure that we are not missing some cryptic mutations in these patients that are not detectable by regular sequencing. So we perform this ADA2 activity test just to make sure that they really don't have ADA2, because we wouldn't like them to miss the appropriate treatment, right? So here is the question about heterozygous carrier, whether they are symptomatic or not. I think that this question can be answered only through large cohort studies. I looked up Jiva's papers thinking, maybe I will find some evidence that some of these cardiovascular diseases have been linked to susceptibility allele in this gene, but I couldn't find any of these papers. Problem could be that these Jiva studies are based on looking into susceptibility alleles or common variants that have allele frequency 5% or higher in general population. Maybe we need to do targeted ADA2 sequencing to identify rare alleles that are associated with various cardiovascular diseases. Pathophysiology of ADA2, I think that we are lacking a little bit there. So here is the paper that showed basically, interestingly, that recombinant ADA2 and ADA1 protein bind to different cell subsets or lymphocytes, so that basically ADA2 preferentially binds to neutrophils, monocytes, in particular to CD16 positive monocytes, to some extent also to NK cells, and these are NKCD56 positive cells. So here is the study from Germany that showed basically that patients with ADA2 have low levels, have hypogammaglobulinemia, low levels of B cells, naive B cells, and especially low level of IgG and IgM. And also, interestingly, they observed that the treatment with anti-inflammatory therapy, namely TNF inhibitors, basically regulated the disease activity or suppressed inflammation in these patients. That was associated with the rise in the IgG and IgM levels. So here is the study which showed another mechanism of the disease in the ADA2. So this particular mutation basically affects one of the conserved glycosylation site for ADA2 protein, so that the mutant protein basically is retained within endoplasmatic reticulum. It doesn't make it into the Golgi, and for that reason, basically, mutant protein is not secreted, as shown here in this panel. So we all knew that inflammation was present in the other two patients at the tissue level, and that's the reason why they respond very well to treatment with anti-TNF, and to some extent also to anti-IL-1. And Okay, so interferon signature. So interferon signature could be a biomarker of disease activity as shown here. So you can see high interferon signature before the treatment, and then it's gone after the treatment with TNF inhibitors. Here is a study from our group, unpublished data, again showing high number of pro-inflammatory monocytes in peripheral blood of patients with ADA2, elevated phospho-STAT1. This is another biomarker for interferon signature. We also showed strong NF-kappa B gene expression signature in patients prior to the treatment with TNF. And so here is important question. So we all know that some of these patients present with bone marrow aplasia and pancytopenia, and the question is really, why is this happening? So is this due to the role of ADA2 as a growth factor, that it's important for differentiation of hematopoietic cells? If this is true, does it really affect the differentiation of all hematopoietic cells or only some hematopoietic cells? And this is very relevant to the treatment of these patients, because if ADA2 really function as intrinsic, basically growth factor important for differentiation of hematopoietic cells and endothelial cell, then it means that basically these patients should undergo hematopoietic stem cell transplantation. If this bone marrow aplasia is due just to an extrinsic defect, which means that there is accumulation of cytotoxic T cells in bone marrow, then it means that these patients should respond to treatment with anti-inflammatory therapy. I will skip this slide. Therapies, we all know that they have very good response to treatment with TNF inhibitor. Here is the recently published study which described 14 patients that were cured with bone marrow transplantation. Gene therapy, we'll hear more today. Enzyme replacement, that's something that we've been talking. However, it's less likely. I'm not aware of any company who is working on development of recombinant ADA2 protein. So we learned a lot. ADA2 testing has been now performed in many diagnostic labs throughout the world. The question is whether we should consider also including ADA2 into a newborn screening, panel. I don't know about that. And more work is needed to understand the pathophysiology of ADA2, but also to understand the function of the ADA2 protein. And enjoy the meeting, and special thanks to Chief Chambers.